Good evening, everyone, and welcome to the DeBakey CV Live Heart Failure Hour, and I'm your host, Imad Hussain. Just keep a couple of housekeeping items before we start and introduce our topic and panelists. If you have live questions, we are taking it. You can either text DeBakey, which is 37607, or you can go to polleverywhere.com, so pollev.com, to send your online questions. So today is a very interesting topic that we have. It's basically pertaining to the current era, the current crisis going on, termed heart failure and the COVID-19 crisis. As this, this is the Heart Failure Hour. So we are going to focus a little bit more on patients that have heart failure or can develop heart failure as a result of COVID-19 infection. So I would like to start by introducing our panelists for today. On my right is Dr. Nadia Fida. She is the Medical Director of Heart Failure and Cardiovascular Imaging at Houston Methodist, Baytown. Then we have on to my left, Dr. Asma Zainab. Dr. Zainab is a critical care medicine doctor. She's an intensivist. She mans our CV ICU. She's an assistant professor of medicine with Weill Cornell and in the Department of Cardiovascular Anesthesia. And then lastly, online, I have Dr. Barry Trachtenberg. He is the director of the cardio-oncology and cardiac amyloid programs. He's also the associate director of our MCS program, and he is the program director of our advanced heart failure transplant cardiology program. So I would like to welcome all our panelists. And with that, I think we should swing into it. So Dr. Fida, I would like to ask you, starting just so that our audience can kind of get a sense, if you could just give us some brief introduction about the SARS-CoV-2 virus, coronavirus 2 virus, how it enters the cell and how it causes infection, and what is the relationship between that and cardiovascular disease, and if there's any data pertaining to heart failure patients in particular.
Yes, thank you, Imad, and good evening, everyone. I think the first introduction, first appearing in Wuhan, China last year of 2019, COVID caused by severe acute respiratory syndrome has quickly become a pandemic declared by WHO on March 11, 2020. Since then, this is very humbling that in the United States there are close to 4 million cases now. And just to explain mechanism of entry of the virus into the cell, first of all, it shares the genetic material which is similar to the SARS pandemic in 2003, and hence the name was changed to SARS-CoV-2. It attaches to the angiotensin converting enzyme 2 protein on the surface of the cell. After it forms a complex, it then is endocytosed into, and after that the ACE2 or angiotensin converting enzyme inhibitor 2 is kind of down regulated. After that, the virus starts replicating. This ACE2 mechanism, and we will talk about it later again, is very crucial in our understanding and especially pertinent to the cardiovascular disease population, where we employ a lot of these medications, ACE inhibitors and angiotensin receptor blockers. So as you can see, this is the surface of the alveolar cell, the cells in the lungs, and the ACE2 is amply available in these cells and other organs. So once this complex is formed, the cell goes inside, starts replicating, and then the formation of angiotensin 2 starts increasing, which can lead to further damage in the lungs and pertinent to the cardiovascular system as well. As we are talking more and more and understanding this disease process and the research studies that are coming out, the mechanism of injury and the biomarkers in COVID-19, the heart failure biomarkers, we have recognized a few. But the susceptibility to the cardiovascular system is broad in the terms of myocardial injury from stressors, from systemic illness, critical illness, hypoxia, hypotension, that then starts the cascade of neurohormonal activation, sympathetic biomarkers, and the biomarkers of inflammation and remodeling. So I think what we know the most is the troponin levels that we constantly measure in all our population when they are admitted for various reasons, for example, with chest pain and decompensated heart failure. Similarly, in this illness, we have seen that troponins are quite a bit associated with not only with the severity of the disease, but also the outcomes, as I'll show later. The BNP is a biomarker of stretch in the heart and the volume overload. And there is some data that suggests that the inflammatory biomarkers like interleukin-6, the CRP, the tumor necrosis factor, ferritin D dimer may be playing a role as well. We have not seen much data pertinent to the myocardial remodeling biomarkers, which are ST2 and galactin-2. As we see here, I think this is a very good state-of-the-art reviews recently published in JACC by Driggins et al. And it shows us the relative frequency of cardiovascular risk factors and underlying cardiovascular conditions in all the available COVID-19 cohorts. And what they have done is also, if you look at the bottom, the last reference, which is close to 13,000, these are the patients, this is the population prior to COVID-19 and taken as a comparator population from China. And then the latter half, the Wu et al. Was a large data set, close to 45,000 patients that were looked at, and then Fang et al. Close to 3,000 patients. And they all these cohorts have really looked at cardiovascular disease, which is mainly a composite of cardiovascular disease, heart failure, and cerebrovascular disease, and the traditional risk factors like diabetes, hypertension, smoking, and coronary artery disease. And we can see that their prevalence in this population is much higher that is infected by COVID-19. CVD about 10.5%, diabetes 7.3%, hypertension 6.5%, which is much higher than the case fatality rate of 2.3%. And this further subclassifies according to the outcomes. And the patients who had these risk factors were more likely to be admitted to either ICU or die. So I think this paints a picture of how cardiovascular disease has a very important measure of how patients with COVID-19 are going to do. When we talk about a little bit more on the incidence of myocardial injury in COVID-19, here we can see all the cohorts that have done it, and as the level of or the incidence of injury increases, so does the mortality. This is just another example. This is stratified by the level of troponin T. So higher the level, higher the mortality. And if we see outcomes like ARDS, mechanical ventilation, fatal arrhythmias like VT and ventricular fibrillation, and even death, more so in patients with higher levels of troponin positivity. So troponin, as I mentioned earlier, remains a very robust biomarker, not only for diagnosis, but also for prognostication of this population. And serially measuring it may have a potential value in further risk stratification of these patients, who's going to do well and versus who is not and needs a further or higher level of management. When we go to a little bit of imaging data in these patients, this another review that came out recently, and this clearly shows that the patients in the cohort of patients that were taken for spectrum of cardiac manifestations in the COVID-19 population and the systematically done echocardiograms, 32% of population did not have 32% of population had normal echocardiograms, and the most manifestation that we see in COVID-19 population is RV dilatation and RV dysfunction, close to 40%. Left ventricular systolic dysfunction was a small cohort, only 10% of cases. And if we go and further, the authors look at what is the association with outcomes. If you look at the death, the parameters out of the echocardiogram that correlated with this were low LVEF, the E to A ratio, which is a ratio of how much is the filling pressures inside the heart, or how decompensated a person is, and the RV end diastolic area, and the myocardial performance index, also known as T index. This is a nice study that was done, that came out of Frankfurt, Germany, that looked at a prospective cohort of people who were initially hospitalized but then have recovered from COVID-19 illness, and they have done MRIs and then matched it to a normal control population. And in this, if we just see it through, the upper two panels show histopathological slides from patients who were severely ill but now have recovered. So this is at the bottom panels show the MRI in the recovered patients. But as you can see, the green lines that mark the native T1 and T2 times on cardiac MRI that are related, that identify the edema or ongoing inflammation, are much higher in this population. The median time to scan from the recovery of, from the diagnosis was 67 days in this population. So these patients have already recovered and are at home. So this is concerning. That this inflammation goes on, and the authors actually rightfully suggested that maybe there should be serial evaluation.
So Nadia, I think for our audience, it sounds like what we're saying is that even when you talk about the cardiovascular disease as being a predisposing risk factor for developing more severe COVID-19 infection and higher mortality, the studies do not reflect per se heart failure patients. They are very vague about defining cardiovascular disease. Is that correct? That
is correct. There are actually very few studies that have actually stratified patients by LVEF. And yes, if the patients, and I think the comorbidity just drives the outcomes here, right, in the setting of COVID-19.
And I guess troponin we can use just for the audience to summarize as a prognostic marker primarily, because troponin could be a marker of myocardial injury, but we don't know if that's true infection from myocarditis or if there's some ischemia going on or what is the cause of it.
Absolutely,
right?
Absolutely. And I think more and more that studies that are coming, and we are realizing there are several mechanisms of injury, and it could be direct myocardial injury versus from the stress or type 2 MI, but the troponin as a prognostication in patients with underlying cardiovascular disease. And how much does it rise also gives us prognostication. And also, as we have realized, COVID-19 is also a very prothrombotic disease as well. So that is also another cause for troponin elevation.
I see. All right. Well, I mean, that gives us a very good segue into, I would like to reach out to our colleague, Dr. Trachtenberg. And Barry, tell us, is there, I mean, for the audience, can you get, is there myocarditis with COVID-19, or this troponin is a bystander?
Yeah, no, it's a great question. I mean, so the truth is probably there's not been clear evidence of myocarditis in the sense that you have everything coming together, including biopsy data that really puts the positive Dallas criteria, which we have for lymphocytic infiltration and myocardial necrosis, with a viral positivity. But certainly, as Dr. Fida mentioned, troponin is a non-specific marker of myocyte injury, and it could be due to sepsis or endothelial dysfunction and hypercoagulability, myocardial infarction in these patients, and PEs. There's so many causes, and myocarditis as well. So the troponin is, we definitely see that's commonly positive in hospitalized patients, but that doesn't mean myocarditis. Similarly, we have a lot of MRI data showing inflammation, and certainly there was a concerning article that came out of JAMA showing that 60% of patients, and these were predominantly patients that had COVID and were not hospitalized. 2/3 of them were not hospitalized, and 60% of them had what we would consider myocardial inflammation or myocarditis by MRI. Now, we don't know any knowledge on the outcomes of those patients. Most of these were not hospitalized, so they probably will have a good outcome. And we don't have any tissue data on those patients. So we have a lot of MRI data. What we don't have is a lot of tissue data. It's been very hard to get autopsy or endomyocardial biopsy data on patients that are suspected of having acute COVID myocarditis due to the concern of spreading COVID to the cath lab or pathology, et cetera. So we do have now probably about a dozen or more case reports that are suggestive of myocarditis. And if you look at the data, if you look at the slide here, you can see that we have certainly patients that have what we would consider myocarditis. So the case report by Sala et al., which is the fourth from the left, was a patient that had clinical myocarditis, MRI myocarditis, and had the classic lymphocytic infiltration that you would see with a viral myocarditis. Now, there was no SARS-CoV-2 replication in the myocardium, which is not a requirement for the diagnosis of myocarditis. So I would say that patient clearly had myocarditis. And we also have evidence that patients may have viral replication without the true inflammatory response of myocarditis. So there was one study in JAMA that looked at 39 patients who died of COVID. Now, these are predominantly septuagenarians and octogenarians. And out of those 39, 24 of them did have SARS-CoV-2 replication. And 16 of those had a significant, what was considered a significant viral load, which is somewhat arbitrary. And they looked at cytokine panels and that they were pro-inflammatory in those 16 patients compared to those that didn't have viral replication. However, none of those patients had a true definition of myocarditis according to the Dallas criteria, showing lymphocytic infiltration in the heart. So we know you can have viral replication, you can have lymphocytic infiltration, but we haven't really seen the two go hand in hand. We have seen patients that are case reports of patients with suspected myocarditis who undergo biopsy do have viral replication, and then they have sort of this low-level inflammation, including macrophages, but really no T-cell infiltration. So it's a bit mysterious in terms of having hard definitive evidence from a large population of having classic myocarditis, but we are seeing certainly a lot of patients with suspected myocarditis, a lot of MRIs that are highly suggestive of myocarditis, but which isn't surprising. We know that viruses cause myocarditis. If you look at the SARS outbreak in 2002, there's autopsy data that had 35% of patients who died did have the presence of viral RNA in their myocardium. We haven't seen it as much with this virus, but I just want to kind of preface all of this with the fact that we're still learning a tremendous amount. There's a lot we don't know, and it's a very humbling disease, and we've had a lot of case reports, a lot of small reports, and I think we'll know a lot more several months down the road.
Okay. So, I mean, it looks like that currently the myocarditis cases we have are limited to small case reports, a small case series. There was an autopsy study, like you mentioned, so one thing that I was wanted to ask you for, and especially for the audience, was so when they looked at the viral copies of RNA, and then when they looked at where they were staining, it sounds like it came into the interstitium in the macrophages. And one thought that would come to mind as a question would be that it's possible that this is just a manifestation of systemic inflammation, and even if you were to look in the kidneys, you would find some macrophages with some SARS-CoV-2, or if you were to look in the liver, you might find some. So it still could be a bystander. But then I agree with your point that like the pro-inflammatory panels, they were positive, so they were suggesting inflammation. So do you think it's a bystander, or do you really think that there is a viral cytopathic effect going on here?
So I mean, I guess it depends on the study. So the study that that we're talking about, this is an autopsy study from Germany, 39 patients, predominantly older, that are less likely to have a robust inflammatory response. And in those patients, most of those patients died from pneumonia. So I think, as to your point, I think the macrophage presence in the interstitium, I think that's probably, that could be from the lungs or from just systemic inflammation. And I don't think that is a proof of an inflammatory myocarditis. And by the Dallas criteria definition, which is probably, is an outdated definition, to be fair, of myocarditis, it is probably not going to be the gold standard forever. But that's what we have, and by that gold standard, those patients didn't meet criteria. So I think in that study aside, I think it's a bystander. But I do think that certainly there is, you would expect there to be patients that do have myocarditis in the classic form from this disease. We've only seen a couple cases that seem to suggest it, which is surprising. But on the other hand, we're not biopsying a lot of these patients. No, so I think if we, there are some sites that are looking to have more histology in the form of biopsies and autopsies. And hopefully once all that's collected, we'll have a clearer picture of what's bystander and what's really causative.
And Barry, there was also a college study on college athletes about looking at patients who had COVID infection, and they had it was an MRI-based study. I don't recall the details. I don't know if you can shed some light on this study.
The reason you don't recall the details is it hasn't been published yet. So this has been in the media. It hasn't been published in a peer-reviewed form, but this has been all over the media as colleges struggle with the decision to come back to play college sports, especially contact sports like football. That there is a study from Ohio State where among Big 12 athletes that had COVID, 15% had myocarditis on MRI, by MRI criteria. Now, the minority of these patients had symptoms. So these are largely asymptomatic patients with COVID that had positive MRI findings. Now, what this means isn't really clear. We know from older pediatric studies of children that have viral infections, if you put an EKG on them, up to 2/3 might have EKG abnormalities. So there's probably a lot of asymptomatic myocarditis in the community from viruses as a whole that we never know about because we're not getting MRIs, and these probably the vast majority of myocarditis will resolve on its own without sequelae. So the significance of this isn't clear. We're talking about findings of inflammation. It's not necessarily that they have the scar or delayed gadolinium enhancement that on repeat MRI, we don't have any of that data. So it is concerning, certainly, as you talk about, playing sports that are contact and having fans in the audience and all, and that you might have this rate of asymptomatic myocarditis. But that study, to my knowledge, has not been published yet. I'm looking forward to seeing that in peer-reviewed form.
Well, thank you very much, Barry. So what it's sounding like to me from a non-expert with COVID-19 and heart failure is that it sounds like there's an autopsy study that shows patients who die from pneumonia, so they already died, and when you do their autopsies, you have potentially maybe some evidence of myocardial involvement, maybe not, maybe a bystander. But then when you look at the MRI study that is done where you're about 70 days out, roughly on mean, it was about 70 days, Dr. Fida,
median,
is that
yes,
correct?
70 days
median
out.
70 days out. So one would like to think that they're in the recovery stages. And so early on, if you don't die from, say, respiratory failure or ARDS, then in the natural history of COVID-19, there's a possibility that down the line, you have some sequelae that are somehow related to myocardial edema. So I guess there was a sort of a Dr. Clyde Yancey did write an editorial on this,
Right.
Basically raising caution that we might be seeing new onset heart failure after COVID-19 infection, and this may be just a marker of just like we get viral myocarditis patients that may have had it in the past, and then we see them down the line with a non-ischemic cardiomyopathy. So, I mean, there's more to, we'll get more data as we go along, but it is suggesting that there is some natural history where heart failure might be playing a role down the line. I don't know if any of the other panelists have any thoughts about that.
I mean, typically, since this is mostly the ones that come to the ICU to us intubated are sick enough to, I mean, I would say like once they come to the ICU, basically they are the sicker one. And with hypoxemia and all that, one of the mechanism of injury, as you mentioned, the troponins are elevated. That could be one possibility, and a prothrombotic state. And with that hypoxemia and being a very prothrombotic condition, we have a very high incidence of thromboembolism in the lungs also, not only at the microangiopathy level, but also as PE. Even those patients who go on ECMO and are on systemic heparin, they're about, in one study from France, about 1/5 of the patients had PE while on heparin and everything. So considering all that hypoxemia and pulmonary embolism, the right ventricular dysfunction is something that we do see. And one of the slides that you mentioned, most of those dysfunction that you saw was the right ventricular as compared to the left ventricular. So I'm assuming the RV failure could be leading eventually to some other, complications related with the heart and all.
So if you, on that lines, Dr. Zainab, is there any role for anticoagulation in COVID-19 patients to reduce the risk of outcomes, or has that shown to improve outcomes in any way?
So it's one of the biomarker, as Dr. Fida mentioned, is D-dimer that we see in these patients, which is elevated. Interestingly, D-dimer in the past we have seen in patients for the thromboembolism, VTE and PE, although its sensitivity is high, but it has poor specificity. So it does, if it is negative, you will say, okay, there is no thromboembolism, but if it is positive, it does not confirm thromboembolism. But in these patients, majority of these patients come in with a high D-dimer, and actually some of those patients initially, if the D-dimer is not that high, down the road, the D-dimer becomes very high, like about 4 times the normal level or the initial level. And it has been seen that the higher D-dimer actually is associated with severe disease and higher mortality in these patients. Considering that, we also know that more recently, one of the papers suggested that the thrombotic phase in the microangiopathy in these lungs is 9 times greater as compared to influenza ARDS, which is significant. Now, considering those patients who the Society for Hematology and Thrombosis has suggested that just based on the fact that the D-dimer is high, we don't do systemic therapeutic heparin. But in patients who we have confirmed thromboembolism, you can start heparin. Otherwise, DVT prophylaxis should be it. We do see quite a lot of patients who go on ECMO. We had at Methodist about 38 to 40 COVID patients who were placed on ECMO. We still have like few who are on ECMO, and being on ECMO, they required anticoagulation. While on heparin, interestingly, we know that whether even in those patients who do not have COVID, we require anticoagulation just because the contact activation of the cascade, and it's a prothrombotic state. But also, we do also know that in ECMO, these patients do lose von Willebrand factor and the glycoproteins from the platelets, so the risk of bleeding is also higher in these patients. So although these patients are on heparin, their D-dimer is elevated, and in spite of that, like I mentioned earlier, in one of the French studies showed patients on ECMO on heparin had 1/5 of those patients had pulmonary embolism. And considering that, we also see that the risk of bleeding on these patients, in spite of being a prothrombotic state, is also high. In generally, in ECMO, there are about 2.5% risk of bleeding. But in these patients, there is one reported study which said about 5% risk of bleeding in these patients. And that's what we have actually been observing in our ICUs as well.
What has been our institutional experience with thrombotic complications on ECMO? And the second follow-up to that is, are these predominantly V ECMO or VA ECMO in terms of, do they also have circulatory collapse?
So let me answer your first question. So we are not seeing anything different than whatever the literature is telling us. These patients are prothrombotic, very high D dimers, and some of them initially, although may come in with a D dimer which is mildly elevated, but may lead to very high levels. And in generally, if we do not have an evidence of VTE, we start them on DVT prophylaxis. If they go on ECMO, of course, they require anticoagulation. And in spite of that, we had some cases that while the PTT was therapeutic, we could see the fibrin threads in the quadrox. And there was one case actually where the patient started having hemolysis with higher haptoglobin level. No obvious source of bleeding and all that. So we thought that it could be because we have seen these coagulant state when the thrombus actually lines the cannulas and leading to hemolysis and all that. And by changing the quadrox, you actually stop the hemolysis. And we have patients who actually, even while on ECMO and on CRRT, required systemic heparin and a pre-filter heparin just because of being a very prothrombotic state. Now coming to your second question about VV ECMO versus VE ECMO, most of our ECMO patients are VV, purely respiratory failure patients. But we had about 2 ECMOs who were VA ECMOs. One of them, a patient who came in, a very young patient who came in with an acute MI. He had like thrombus at least in 2 vessels. I don't remember if it was one was the LAD or a circ or something, and in a hemodynamic collapse as well, requiring a VA ECMO while they did the PCI and all that. Luckily, this patient survived, and within 3 days, we were able to come off of the VA ECMO. His hemodynamics improved because his main issue was there was no previous history of coronary artery disease or any family history of early coronary artery disease, no other risk factors other than just he was COVID positive. Although he did not have any respiratory symptoms with that, no fevers, nothing, it was just incidental. And another VA ECMO is still in there, and you're probably aware of that patient who was a heart transplant patient who required VA ECMO, and we still don't know what led to this hemodynamic collapse. But again, in this particular patient, it was not the lungs which was the main problem.
It was not the lungs that was the main problem. So we are seeing cardiogenic shock as part of the profile, but not as frequently as the respiratory failure and ARDS. Okay. So, I mean, I do have one segue to a question that I would like to ask you, and then probably also lead to Dr. Fida with regards to that. So we've talked about if you have cardiovascular disease, you are at a higher risk for getting COVID-19 infection with higher severity and a higher mortality. We established that. So that's one unilateral relationship where you have underlying cardiovascular disease and you're getting COVID-19. How about the other way around? Does COVID-19 cause cardiovascular disease? And in that regard, we have talked about potentially myocarditis being one of the often if you have pre-existing heart failure, although we don't have our institutional experience, there have been reports of VA ECMO in the setting of a combined septic cardiogenic shock picture. But then leading to that, there was in the pediatric population, there was a study where they talked about patients with COVID-19, kids with COVID-19 that then developed the hyperinflammatory response, cytokine storm, and presented with very classic symptoms of what we used to see with Kawasaki's disease, where they had coronary artery involvement, aneurysms, and they had like the whole prodrome where Either it's an endothelitis that we know that the endothelium is very rich in ACE2, or there is something else in terms of microthrombotic complications that is resulting in this phenomena of a sort of a heart involvement directly. So in that light, what I'm saying is, what I'm trying to get at in a set way to my question for you, Dr. Zainab, is if you have pre-existing cardiovascular disease, you may not have yet manifested as having structural heart disease, you may not have known heart failure, but then you get this COVID-19 infection and all the milieu that goes with it, systemic inflammation, prothrombotic state, endothelitis, endothelial dysfunction. You could develop, manifest, not necessarily HFrEF, but maybe acute diastolic heart failure, especially in the setting of COVID-19 patients where we're giving IV fluids, we're treating them like sepsis. So my question to you is, if a patient does develop ARDS and pneumonia, how do we differentiate that truly have ARDS or they don't have true cardiogenic pulmonary edema? And is there any role for using PA catheter in these patients to specifically tailor therapy?
I guess there is a role, especially when we are seeing more cases of right ventricular dysfunction, and whether you want to know, because at one stage the X-rays become the same.
Yes.
They are all like whited out bilateral infiltrates day by day. You have the same thing. Although we do keep them on the drier side and all that, then the next thing you see is like their creatinine start going up and all that. So you're trying to keep balance between keeping them on the drier side and diuresing them to keep the and then at the other side you want to protect the kidneys as well, to have the second organ failure. Unfortunately, because the way the disease is, we try not to do too many procedures on these patients. So far, we have not tried pulmonary artery catheter in these patients. Most of the time, the hemodynamics are measured. Mostly, we have an art line and we use the CVP and the non-invasive methods of figuring out where the cardiac output and all that. So maybe there is a role. I guess we all have to brace for going a little bit more aggressive with these patients to know what's going on, and then accordingly treat these patients.
And so something prospectively that we can see if, at a hospital institutional level in terms of a protocol or moving forward perhaps.
Yeah. I do want to add something to it. In the difference of practices in an academic center versus community hospital, right? What we have seen in Baytown, and we have not looked at it in a systematic way, but just recalling the cases, especially the patients, though we have not discussed this particularly here, but morbidly obese population that were stable, younger morbidly obese population, males and females, who don't have a lot of underlying other diagnosed risk factors, came in with mild to moderate disease but did not recover, ended up in ICUs, and then oxygenation becomes a problem. At that stage, we have actually done a lot of Swan-Ganz catheters, and they have quite a bit of manifestation of pulmonary hypertension, and which leads to all this, the RV dysfunction that we see, and kidney injury then starts because we can't diurese them adequately. What is also notable, again, we haven't looked into it in detail, is that they respond very nicely to maximum strengths of inhaled Flolan. Then we cannot do any other systemic therapies for them.
Makes a lot of sense. So I think that's a very thorough discussion about the critical care aspects of COVID-19 and heart failure patients or cardiovascular disease patients. Nadia, there's this thing out there that people, several of our patients, we receive phone calls in clinic about they're on lisinopril or they're on losartan, they're on ARBs or ACE inhibitors, and they're very worried because they read all these things in the press about whether they should be continuing these medications. And as you know, it's a ubiquitous use. It's not only used for heart failure, but it's also used in treatment widely for hypertension and chronic kidney disease. What is the data out there? What does the data tell us?
Yeah, absolutely, and that's a great question. And I think to understand it a little bit better, we're going to come into the detail of this a little bit more. So, as Dr. Hussain has said, the ACE inhibitors or angiotensin converting enzyme inhibitors and angiotensin receptor blockers are bread and butter of cardiovascular disease risk modification and treatment, and especially for heart failure patients, hypertensive, diabetic patients, chronic kidney disease patients. And these are one of the very first medications that showed that they start reversing the fibrosis and reverse remodel the myocardium in heart failure. So there is a lot of data out there, and the data is conflicting till about now. There is a data that says that since the virus uses the angiotensin converting enzyme to form a complex, and with that aids into entry into the cell, is that the reason that once we have patients on these medications, that the virus is being on these medications upregulates these receptors, and then there are more receptors available for this virus to cause harm. And is that the reason that the patients are having bad outcomes? Because many of the cardiovascular disease patients who are having bad outcomes are also on these medications.
Sure.
Versus this, there is a hypothesis that if you take the patients off on when they are stable on these medical therapies for their chronic conditions, now you take them off and you start down-regulating the mechanisms that were beneficial, and you up the more production of angiotensin 2 that leads to more injury of the lungs and a cardiovascular system. Is that the reason? So till now we in the ESC recently there was a late-breaking clinical trial, BRACE Corona, that came out, that has actually done a randomized control trial. So BRACE Corona is a pragmatic trial continuing versus suspending angiotensin converting enzyme inhibitors and angiotensin receptor blockers and their impact on adverse outcomes in hospitalized patients with coronavirus. So it's a national registry on suspected and confirmed cases of COVID-19, and it's a one-on-one randomization. They have enrolled about 659 patients when they presented in an ESC, and patients were either taken off of ACE inhibitors and ARBs for 30 days or they were left on it. And then the patients who were included in the trial were all adults hospitalized with a confirmed case of COVID-19. And the patients who were excluded were either too sick or decompensated in the last 12 months. They were requiring a lot of medications for their blood pressure management. The sacubitril valsartan or Entresto patients were not included in this trial. Patients who are on mechanical ventilation or hemodynamically unstable or pregnant patients were not in this trial. So the primary outcome of the study was number of days alive and out of the hospital through 30 days was no different. So 21.9 in the patients who had suspended treatment, and compared with 22.9 in the continuing group. And the secondary outcome of all-cause death at 30 days, 2.7% in the suspended group versus 2.8% in the continuing group. So I guess the take-home message that we can at least take, that it's a randomized trial in a large academic center, and we have seen that among patients who are hospitalized with COVID-19 infection, receiving chronic ACE inhibitors and ARBs versus suspending them is not beneficial. So suspending the therapy compared with continuing them did not improve the days alive or out of the hospital. I think the main limitation of the trial is it still does not answer the question of this mechanism that the virus binds to ACE2. What about the patients who are hypertensive on it but do not have COVID-19? What should they do? So I guess there is a limitation of the trial, but this is the first randomized trial. So, and a lot of other cohort studies that have said the same thing, that discontinuing the therapy is probably more harmful than beneficial.
Sure. I mean, so it looks like, Nadia, this randomized trial is basically consolidating what the retrospective data is showing, that whether you're on ACE inhibitor or not does not increase your risk of viral infection, number one. Number two, it does not increase the risk of death, nor does it increase your length of stay.
Correct.
So the retrospective data is clear on that, but then now we have a randomized control trial showing you whether you suspend it or not. The question I have is, could it be beneficial? Because someone is not on ACE inhibitor, or they will have unopposed angiotensin 2 as a result of COVID-19 infection, and they could have a more pro-inflammatory state. So I think there are some trials undergoing that are currently not out as to whether there may be a beneficial role of ACE inhibitors or ARBs in this population. One question I did want to ask you regarding that, so that is like if they're outpatient, they're on ACE inhibitors, ARBs, they have mild infection, they get admitted, okay, with mild symptoms, you continue ACE inhibitors, ARBs. But what happens when, like, day 7 or 10, they get sicker, there's a cytokine storm that hits, they're now getting a little hypotensive, they're on ARDS, they're not developed ARDS, but they're getting hypoxic, they're getting respiratory failure, they're getting worsening pneumonia. Now it's a matter of time before they get hypotensive, start having renal failure. Would that be a reasonable time to maybe consider stopping ACE inhibitors or ARBs?
Well, and that's a great question. I think if the patient is a borderline at the verge of hemodynamic collapse, then we don't have an option. But patients who are kind of maintaining their blood pressure, should we just lower the dose and watch, or switch them over to a shorter acting ACE inhibitor ARB to have a closer monitoring? Could be a way to go, but yes, I mean, we don't have data to back it up or not at this stage.
Well, interestingly, there was like a study that was done like years ago before COVID came in, and that was on ARDS. Basically, it's still a bench study, not gone to the bedside yet, but they found that mice with ARDS, when they induced ARDS in the mice and they were given ACE inhibitors, it reduced the fibrotic state of ARDS. So I don't know, like if it has a role in ARDS patients to prevent fibrosis as well.
Yeah, I mean, because one thing that we do know that ACE inhibitors do even clinically is that they present with dry cough, and one of the mechanisms is bradykinin. And so increased bradykinin can cause bronchial hyperreactivity. And it may be that is actually not good in a setting when you have a pneumonia, respiratory failure, you're having difficulty oxygenating. But I think it remains controversial in that setting whether one should continue or not. Most definitely, if someone became hypotensive and started developing acute kidney injury at that time, I think we will all be discontinuing these medications. But it's a very interesting thing as to how to pursue this for the more sicker patients that have COVID-19. In the last few minutes we have before we take some questions, I wanted to reach out to Dr. Trachtenberg, and I want to switch a little gears to patients, because heart failure is a spectrum. We have our advanced heart failure patients, we have patients that are listed for heart transplant, and then we have patients that are in the hospital on temporary mechanical circulatory support. I mean, the COVID-19 hit, but they're still waiting for their hearts. What is our institutional experience, or what has been our policy around our listed patients in terms of transplantation, and what was our experience with heart transplants in this COVID-19 era, Barry?
Yeah, no, so great question. I mean, I think we did. I'm sure many programs across the country have struggled with this question, and I think we kind of tailored our decisions to the percent case rate was, the positivity rate in the community at the time, and which wave of the pandemic we were in. So when we were at the first what we call the peak, although it turned out to be kind of the hill compared to the second real peak that we had subsequently, we really we would patients that are listed status 1 or 2 that are hospitalized on temporary mechanical support or inotropes, we never stopped transplanting those patients that are already in the hospital. We did try to avoid bringing patients in from home for a transplant during the 2 peaks unless they were someone that was really struggling at home, or was someone that that was really hard to get a match. For example, a patient on an LVAD that was blood type O, or a highly sensitized patient where that they may not get another opportunity. So we really had to weigh the risk of the patient coming into the hospital during the peak of the pandemic and getting COVID, which has happened, and with the risk of missing their opportunity for transplant and dying from heart failure, which is also a real possibility because these are sick patients. So we did back down a little bit on the transplant volume during the 2 peaks, but in between we opened it back up to the waitlist population at large. But we did end up doing a fair number of transplants during these waves, and with good success. We have had a couple patients that had a transplant recently get COVID. Fortunately, no one has died from that, but they did have COVID. We have had an LVAD patient who got COVID on his index LVAD hospitalization, but thankfully did well. And that's consistent with the literature. So for Mount Sinai, Aditi Singhvi and colleagues published their experience where they had out of 400 patients that had a heart transplant in their program during New York and during their pandemic. They had 20, I think they had 23 patients that had COVID, and so these are all patients that that have been transplanted in the past X number of years, not necessarily acutely. And out of those 22 patients that had COVID in a prior heart transplant, 5 of them died. So 23% of them died. And 4 out of those 5 that died were at another hospital, not in their institution. And perhaps they managed the patient differently at the non-transplant centers. And they looked at numbers for other hospitalized patients, and it was similar, 18% fatality. So overall, there's no evidence that transplant patients are more likely to die with COVID if they're hospitalized compared to non-transplant patients. So that's encouraging, and we've certainly seen that here as well. We've had as high as 15% of patients with all organ transplant have COVID, or patients that were tested have COVID during the worst peak. And overall, the survival was fairly comparable to other hospitalized patients. In the Mount Sinai experience, they also proceeded to do transplants. They had 5 transplants at the time of their publication, and 1 of them did get COVID and had just a mild manifestations from COVID. Mm-hmm. So I think the bottom line is, patients do need to have end organ interventions, and you can't put your program on hold for a pandemic. But certainly if you're careful about it and you try to choose the sickest patients that really need an intervention, and do your best that you can to have them avoid COVID, then that was our strategy. And even with that, you're going to have some patients that do get COVID after their index hospitalization, but they are overall with comparable survival to the population at large.
Okay, well, thank you very much. And I think that we only have a few minutes left. First of all, I'd like to thank the panel for an excellent discussion, but I would like to open it up for any online questions at this time, if there are any, or any comments from the audience. All right, so there's no questions, it looks like, at this point. Okay, well, thank you guys for joining us today, this evening, for the Heart Failure Hour. Again, I would really like to thank my esteemed colleagues and panelists for being here. And then just to announce that the next session, so the Heart Failure Hour is the second Thursday of every month. And so the next time we're going to have, the topic will be updates on heart failure with preserved ejection fraction. So thank you for your time, and good evening to all, and have a nice evening. Thank you.
Thank you.